Welcome back to the deep dive. Our goal here is to hand you the most essential insights from some pretty complex material, making sure you're informed without having to wade through, hundreds of pages.
hmm
Today, we're diving into the reality of effective drug therapy in the 21st century. And it's a world that is just so much more complex than just filling a prescription. Okay, let's unpack this.
Yeah, our mission today is really to explore the major challenges to effective drug therapy. We're tackling these massive new pressures that have um, completely changed the relationship between patients and providers.
We're talking about a flood of information, right?
A total tsunami of information, plus crushing financial constraints, and on top of that, new public safety concerns from the opioid crisis all the way to bioterrorism.
And what's really key for you, the learner, is to get that the old model of healthcare is just gone. This idea of the single omniscient provider whose word was law.
That's history. It really is.
Patients today have constant access to information, they're demanding specific treatments, and they are actively using self-care alternative therapies.
Precisely. And the core challenge for providers, especially for nurses, is just navigating this new landscape. The nurse isn't just administering medication anymore. They're now a primary teacher, a skeptical advocate, and a sort of knowledge broker, helping patients make safe choices in a really confusing world.
Let's start right there with that information explosion. I think the biggest one is media and direct-to-consumer advertising, DTC ads.
Oh, yeah.
Since it was legalized in the US in the 90s, it just feels like drug ads are everywhere, and that creates this immense pressure.
It does. And legally, the federal guidelines are actually clear. If an ad states a drug's use, say this is for high blood pressure, it then has to disclose all the major contraindications, adverse effects, all of it.
But the industry found this. I mean, it's a genius way around that rule, isn't it?
It is a brilliant business ploy.
If they don't say what it's for, they don't have to list the scary side effects.
That's it. They sell the feeling instead of the function. I mean, think about those ads for, say, sildenafil or Viagra. You never see the medical indication listed.
No, you just see happy dancing couples.
Exactly. Vital, happy, older couples. And then it's followed by ask your doctor. The ad is selling youth and confidence, and it forces the patient to start a conversation about a drug the provider might not even think is appropriate.
And it's not just commercials either. It's the disease of the week phenomenon. You see a complex medical report get sensationalized in the media, and suddenly patients are coming in demanding tests or drugs based on a headline, not their actual symptoms.
It's a huge source of frustration for sure. But the real information challenge has to be the internet. Just instant access on phones, on tablets, means patients are just overwhelmed.
The problem isn't getting information, it's figuring out if it's any good.
Right. Is it accurate, or is it just anecdotal noise? It's tough.
So if a patient comes in with, 10 pages they printed off the internet, how do we filter that? The sources give us a really crucial tool for evaluating websites. It starts with the address itself.
Yeah. The URL.
Yeah, you want to look for addresses ending in .gov or .edu. Those are generally reliable government or academic sources.
As opposed to, say, a .com, which is commercial, or even a .org. Those just require a lot more scrutiny.
All right. And beyond the address, you need to think critically. How easy is the site to use? Who's writing this stuff? Are they qualified? When was it last updated?
And most importantly, does this information actually match up with what you know from other, more reliable sources? That's the core skill for any healthcare consumer today.
This all sets the stage for the next big area, which is this growing world of self-care. Over-the-counter drugs, OTCs, they're defined as safe when you use them as directed, but I think people forget that a lot of common drugs, like aspirin, were kind of grandfathered in decades ago.
Without the same stringent modern testing we require today. That's a really important historical point. The FDA is always reviewing these older drugs.
Like what happened with Ipecac syrup.
Exactly. For years, it was the standard thing to make someone vomit after a poisoning. But the FDA finally reviewed the data, and in 2003, they announced it was basically ineffective, which forced a whole new set of guidelines.
So OTCs support this idea of self-care, where patients are diagnosing and treating themselves. But that has limits. The sources mentioned lovastatin, the cholesterol drug, was denied OTC status. Why was that?
Because you can't self-diagnose high cholesterol. There are no signs, no symptoms you can see or feel. It takes a blood test. So if a patient could just buy it over the counter, they might be treating a condition they don't even have. Or worse, ignoring a much more serious underlying problem.
And that gets to a huge safety warning. OTC drugs can mask serious conditions. But the biggest immediate danger seems to be combining them.
Oh, absolutely. So many common cold, cough, and sinus remedies are these combination preparations.
Right.
So you take one thing for your sinus pressure, another for your cough, a third for aches. And you can easily end up with a toxic, unintended overdose of ingredients that are in all three of them. Things like pseudoephedrine or dextromethorphan. It's a critical point for assessment.
And it means nurses have to be so specific when they're taking a drug history. Patients just don't think of OTCs as real drugs.
They don't. You can't just ask about prescriptions. You have to ask, are you taking anything for colds, for headaches, to help you sleep?
That level of detail is non-negotiable. And I imagine the same caution applies to alternative therapies.
Even more so. These are natural products, herbs. And look, many of them are the original basis for modern regulated medicines, but they're classified by law as dietary supplements.
Which means they are not subject to the FDA's control. No testing requirements.
None. They can advertise, but they can't make claims about curing a disease. They can say things like, supports memory, or for hot flashes.
And that lack of regulation leads straight to the main safety issue, which is variability, right?
It's all about variability. If the ingredients aren't standardized or tested, what are you actually taking? The sources mention a study of saw palmetto samples where the active ingredient varied from just 20% of what the label said all the way up to 400%.
400%. Wow.
That kind of inconsistency is just inherently dangerous.
And here's where it gets, I think, really interesting. The drug interactions. This is the nightmare scenario.
It is. Take a diabetic patient, for example. They might use certain herbs like juniper berries, ginseng, or garlic to try and naturally manage their blood sugar. But if they combine those with their standard prescription anti-diabetic drugs, they risk serious, even life-threatening hypoglycemia. The synergy can just crash their blood sugar.
And the most notorious one for interactions is always St. John's wort.
Yes. St. John's wort interferes with a staggering range of medications. It can make oral contraceptives less effective. It interacts dangerously with digoxin, theophylline, antivirals. And this is crucial. If a patient takes it with an SSRI like fluoxetine for depression, the combination can cause toxicity.
So asking about herbs has to be a mandatory part of every single patient intake.
No question.
Okay, let's pivot now from patient choice to systemic pressures, starting with off-label uses. We hear that term a lot. What does it actually mean?
It just means using a drug for an indication that the FDA hasn't officially approved. So the drug itself is regulated, but the specific reason the doctor is using it for isn't on the label.
And this is pretty common in a couple of areas, right? Like pediatrics.
Very common in pediatrics because there are ethical limits on testing drugs on children. So it requires these really complex, calculated dosing strategies. And it's also common in psychiatry, where a sort of polypharmacy approach is often needed because brain chemistry is just so complex.
So for the nurse, it's about knowing why a drug is being tried. Is this standard practice or is it more experimental?
Exactly. That awareness protects both the patient and the prescriber. And this whole issue is tied directly into the skyrocketing costs of healthcare.
Which brought us the rise of the HMO, the Health Maintenance Organization.
Right. Where healthcare is treated more like a business, with centralized control that often puts finances ahead of ideal medical choices.
And their main tool for that is the formulary.
A formulary is a regulated list of the specific drugs that the HMO will agree to cover. Sometimes it's only generics, or there's a tier system that favors the cheapest drugs. It directly limits a physician's choice.
And that cost pressure just lands right on the patient. We have to talk about cost comparison and this just devastating reality of patients being forced to choose between, well, treat or eat.
It's one of the most serious ethical dilemmas in modern medicine. Patients won't fill prescriptions because they can't afford them, or they'll stop a course of antibiotics halfway through to save the rest for later.
Which we know contributes directly to antibiotic resistance.
Berkeley.
And sometimes, to save money, patients will try to split their pills. We need a really strong safety warning on that.
Yes. Do not split tablets unless you are specifically told to. So many modern drugs use a matrix delivery system, a time-release coating. If you cut that pill, you destroy the system. You could get 12 hours of medicine in the first 10 minutes. It can make the drug useless or even toxic.
On cost. And let's quickly touch on generics versus brand names. Generics are off patent and they're tested for bioequivalence.
Meaning they have to have the same active ingredients, yes. But some prescribers will still write DW or dispense as written.
Why would they do that?
Usually for drugs with a very small margin of safety, like Lenoxin versus its generic digoxin. They want to control the binders, the fillers, the dosing as precisely as possible. And a quick note, the generic isn't always cheaper. You still have to compare.
And that pressure to save money is what pushes people to buy cheaper drugs online from other countries. The FDA warns against this constantly.
And for good reason. You lose all legal protection. The risks are huge storage problems where the drugs get too hot or cold. You might get something completely different from what you ordered, and you're dealing with foreign brand names that don't match U.S. generics, which leads to confusion and errors.
All these financial pressures also mean patients are getting discharged from the hospital sooner, which has fueled this booming home care industry. So what does that all mean for patient education?
It means the responsibility for really complex care, we're talking dressings, monitoring, detailed drug schedules, it all falls almost entirely on the patient or their family. The nurse's role as the primary educator becomes paramount.
So the teaching has to be just airtight. Medication names, doses, how to handle expected side effects, like eating small meals for GI upset.
And specifically, how to avoid those dangerous OTC or herbal drug interactions we talked about.
It's practical stuff, too.
Absolutely. Where to store the medication, so not in a hot, humid bathroom, how to secure controlled substances, and providing all of this information in clear, simple written language.
Okay, finally, let's turn to these large-scale public health and safety challenges. Since 9/11, emergency preparedness has become a huge concern, especially around biological weapons germ warfare.
Right. The use of bacteria, viruses, parasites against a civilian population. The CDC is constantly working on guidelines for exposure, for management, coordinating a response, and education is just central to coping with that threat.
And then we face the absolutely crushing reality of the drug abuse epidemic, which is just dominated by the opioid crisis. The numbers are just tragic. Over 90 Americans dying every day from an overdose.
And it started with a well-intentioned push in the 1990s to treat pain better, combined with these assurances from drug companies that addiction was unlikely if the drugs were prescribed properly.
Which we now know was just dangerously wrong.
Dangerously misleading. Research shows up to a third of patients misuse the drugs. And critically, 80% of current heroin abusers started by misusing prescription opioids first.
So the solutions have to be multifaceted. Tightening controls, making reversal agents like naloxone widely available, and just pouring money into research for safer pain treatments.
And then there's the whole world of illicit street drugs, no therapeutic use at all, which lead to these severe health consequences, including actual persistent changes in the brain's neurotransmitter patterns.
Our final safety challenge is an environmental one. Studies keep finding prescription drugs in the drinking water of major cities.
Mostly from improper disposal, flushing them down the toilet or just tossing them in the trash.
This is a huge teaching opportunity. The Office of National Drug Control Policy has specific guidelines.
Right. Take drugs out of their original containers, mix them with something undesirable like used coffee grounds or kitty litter.
Then put that mixture in a sealed, nondescript container and throw that in the trash.
And you should only flush a drug if the patient info specifically says it's safe to do so. The absolute best route is always a pharmaceutical take-back program at a hospital or a local government site.
So, to synthesize this entire deep dive, the modern healthcare environment demands that providers manage information overload, police dangerous self-care choices with unregulated products, navigate these profound financial pressures, and act as public safety agents against threats from opioids to environmental contamination.
Yeah, it really makes the nurse, and by extension, the educated patient, the central, indispensable monitor of a drug's efficacy and safety.
What's fascinating here is the massive tension this creates. On one hand, you have the system pushing for cost-cutting through tightly regulated bioequivalent generics. On the other hand, you have the growing popularity of completely unregulated, highly variable herbal supplements.
It's a real conflict.
So given that tension and the financial pressure pushing patients to shop online outside of any FDA oversight, what are the next major ethical and safety battles we're going to face in controlling the drug supply chain? It feels like this tension between finance and safety is only going to get more complex.
That's a profound question to take away, for sure.
Thank you for joining us for this deep dive into the modern challenges of effective drug therapy. We'll see you next time.